Hello, everyone. My name is Danielle Chrisman, and I'm the project manager for the Canadian Dementia Learning and Resource Network. Just skip ahead to the next slide here. So we're going to begin today with land acknowledgement. Then we'll share some housekeeping details, say a few words about CD Learn, and I'll introduce today's speakers. The RIA acknowledges that we are on the traditional territory of the Attawandaron, Anishinaabe, and Haudenosaunee peoples. The RIA is situated on the Haldimand Tract, the land promised to the Six Nations that includes 6 miles on each side of the Grand River. We further acknowledge that many other nations are represented today at this meeting. We hold deep respect for Indigenous histories and recognize the enduring presence and resilience of Indigenous and treaty peoples in this area and across Canada. This acknowledgement is a reminder that we are all accountable to these relationships and have a part to play in reconciliation. We further commit to build relationships that enhance and better serve the needs of Indigenous people and all others experiencing dementia or partnering in their care. We'd also like to offer an opportunity for others to offer a land acknowledgement of their own in the chat. I'll also share a link to nativeland.ca, which will allow you to see what land you are on, if you don't know. Share just quickly about CD Learn before I introduce our first speaker. CD Learn is short for the Canadian Dementia Learning and Resource Network. CD Learn is a knowledge hub led by the Schlegel UW Research Institute for Aging and is funded by the Public Health Agency of Canada under the Dementia Community Investment, the DCI. These projects funded by the DCI, they focus on the development of innovative tools, resources, and approaches that enhance the well-being of people living with dementia and care partners by increasing awareness, support, knowledge, and understanding of dementia. These innovations, like supporting a circle of care, are shared broadly to support dementia policy and practice across Canada. So now it's my pleasure to introduce Laura Alfaro, who is a researcher and project officer at the Native Women's Association of Canada. She's here to share with us about her current project, Supporting a Circle of Care.
Thank you so much, Danielle, and thank you to CD Learn for giving me the opportunity to talk about the project. I would also like to acknowledge that I'm coming to you from the unceded and traditional territory of the Secwepemc Nation in the interior of British Columbia. I live 2 hours northeast of Kamloops. So the project is called Supporting a Circle of Care, a culturally informed support group and toolkit for Indigenous caregivers of people living with dementia, and that is a very long title. So we like to just call it Circle of Care, and that's what we usually refer to the project as, a Circle of Care. Danielle, if I could have the next slide. Yes, thank you. So I'm going to provide a little bit of background on our project. Circle of Care is funded by the Public Health Agency of Canada's Dementia Community Investment. And we are very grateful to have the funding for this project, because we know that dementia has increased dramatically in Indigenous communities over the last decade. So this project was created to provide education and support for Indigenous caregivers of people living with dementia. In many communities, many Indigenous communities, dementia care is typically provided by a family member. And so while we acknowledge that this can be a very rewarding experience, and many caregivers that we've spoken to talk about it as being a rewarding experience, and it's allowed them to become closer to their loved one, we know that it comes with its own set of challenges. And so this is why Circle of Care focuses on the caregiver. So our target population, the project addresses the needs of Indigenous women, girls, and gender diverse caregivers of people living with dementia. It aims to provide support and information to caregivers who continue taking care of their loved ones, but we also want to recognize that they need to prioritize their own well-being also. So as I mentioned, even though providing care can be rewarding, it's very demanding on a caregiver's mental, emotional, physical, and spiritual well-being. So caregivers we've spoken to will report having issues with sleep, anxiety, depression, burnout, feelings of frustration, financial challenges, and feelings of social isolation. These are all concerns that caregivers have spoken to us about repeatedly. So the resources developed through this project were designed to improve the mental, emotional, physical, and spiritual well-being of Indigenous caregivers. And we're hoping that this is going to enhance their ability to care for their loved ones. The project seeks to help caregivers increase their understanding of dementia and equip them with the skills to manage their loved one's condition. The project also seeks to benefit people living with dementia by providing tools that will enhance the care they receive. So as we know, when caregivers struggle, their level of care struggles as well. This project was designed with several resource sharing components, and this is expected to mitigate the stress and burden that caregivers feel. So I'll maybe take some time to talk a little bit about the toolkits, which are designed to address some of the main challenges caregivers face. So there are three main components to the toolkit. The first one is a guidebook, which provides tips and strategies on self-care, understanding loved ones' needs, and developing a support network. The second part is the logbook, which helps caregivers plan ahead, record important information, and document aspects of their journey with their loved one. It's also a very valuable resource for caregivers whose loved ones are in long-term or respite care. So a number of our caregivers are not living with their loved ones full-time. Some of them are in care facilities. Some of them are, when the caregiver needs a break, they're in respite care. And so having a logbook, helps to keep things, keep track of things such as medication, meal times, favorite activities, etc. And this also helps to facilitate the maintenance of routine, which, is very important, central to the well-being of a person living with dementia or memory loss. The third is a guide that was created for sharing circles, to develop sharing circles in different communities. So this provides information on how to start a sharing circle in a caregiver's community. And it includes information such as the importance of finding a navigator who can act as a guide for community members and connect them to resources and supports. The navigator can also support community members by facilitating sessions and informing participants about the resources available to support dementia care in Indigenous communities. It also outlines cultural considerations, for instance, having an elder present at the circle to open and close it. And we find that grounding the circle in culture is a good way to make people feel comfortable and connected to one another, which is very important. It helps with the sharing. And again, it creates a space that can help support healing. So I'm going to talk a little bit more in depth about the sharing circles, because this is the activity that we've been focusing on in the past several months. So as part of the project, NWAC has been holding virtual sharing circles for Indigenous caregivers across Canada since the end of January. So when the project was first developed 4 years ago, the sharing circles were going to be in person. They were meant to be in person. Obviously, the pandemic sort of changed that plan. But one of the advantages of having virtual sharing circles, is that we can get so many different perspectives from people across the country. So it's really been wonderful to hear from different parts of Canada, people's experiences. So that's definitely been one of the benefits of holding the circles over Zoom. So prior to the circles, we did share parts of the toolkits with participants so that they could have time to review the materials in the toolkits. And they were also encouraged to provide feedback about the materials. So if there was anything that they felt we hadn't covered, questions they had, things that they felt were important to add for other caregivers to know, we wanted this information. So we shared drafts of the toolkits with them. The circles were facilitated by Dr. Danielle Alcock from the Southwest Ontario Aboriginal Health Centre. Dr. Alcock is a member of the Chippewas of Rama First Nation, and she's done extensive research on storytelling of female Indigenous caregivers supporting a loved one with memory loss. She also has a great deal of lived experience as a caregiver for her father, who was diagnosed with dementia about 10 years ago. And in addition to Dr. Alcock, we were fortunate enough to have a knowledge keeper in attendance at the circles. The knowledge keeper, her participation included opening and closing the circle in a good way. She was also present during the circle the whole time to provide extra support as needed. And this was especially valuable given the type of sharing that was happening. Many people shared, feelings of grief, loss, feeling stressed, feeling burdened. So it was definitely very helpful to have the knowledge keeper there to provide that support. It was also great to have her there because she had been a caregiver herself to several family members who had been diagnosed with dementia. So she was able to discuss her experiences in the group discussion as well. When participants spoke about self-care and coping strategies, the knowledge keeper would often share that one of the main ways that she found was a good way of coping was through art. So she would share some of her artwork with participants, and this resonated deeply with many of the people in attendance. And the circles also allowed participants to ask any questions they might have about caring for a loved one with dementia, and they also were able to share their knowledge and experience with other caregivers. And as I mentioned, sharing was sometimes difficult, but participants responded very positively to connecting with and learning from other caregivers. Information was exchanged about resources that are available in person and online, so things like websites, books, programs available to caregivers in different communities. Caregivers also shared self-care and coping strategies. And we did find a number of similarities. So for example, the importance of sleep, bodily movement. People shared the importance of, being physically active, doing things like yoga, the importance of land-based healing. So going up for walks, being out in nature, being near bodies of water, something that we heard repeatedly. And mindful activities, such as meditation. Meditation came up in almost every single one of the sharing circles. So that was very interesting to learn. And so this collective sharing captured one of the main objectives of the project, which is to build strength and support through community. So as I mentioned, feedback from participants about the sharing circle was very positive. And this confirms to us the importance of continuing this initiative. So moving forward, NWAC intends to post the toolkits on its Aging and Dementia website, and with the hope that it'll encourage Indigenous caregivers across Canada to start their own sharing circles. Copies of the toolkit are also going to be printed and distributed through NWAC's provincial and territorial member associations to promote and sustain the longevity of the initiative. And we hope that this will support caregivers and their loved ones in their dementia journey by emphasizing the importance of expanding one's circle of care and continuing to find strength through community. We also hope the resources developed through this project can provide ongoing evidence-based and culturally appropriate support and contribute to the well-being and resilience of Indigenous community members across Canada. Thank you so much.
Thank you so much, Laura, for that really helpful overview of this exciting and much needed resource. Everyone who registered for this webinar, we have your email address. So you'll receive an update when the toolkit is released and able to be accessed online. So please stay tuned for that, likely towards the end of March, about 2 weeks. So now I'm pleased to introduce Dr. Melissa Blind from the Indigenous Cognition and Aging Awareness Research Exchange, iCare. Melissa is originally from George Gordon's First Nation in Saskatchewan and now works as a senior research associate on the Memory Keepers Medical Discovery Team at the University of Minnesota Duluth campus. She has over 10 years experience working with Indigenous communities in the field of Indigenous health and dementia research. So I will hand things over to Melissa.
Thank you. Just share my screen here. So thank you for that introduction to Danielle. And thank you to CD Learn for inviting me to speak today. Also, thank you for everyone joining the webinar. I'm here in Duluth right now, Duluth, Minnesota, and it's the traditional and contemporary lands of the Dakota and Ojibwe people. I was really excited to hear about the launch of NWAC Circle of Care Toolkit. So this toolkit will add to the much needed culturally safe dementia resources and will provide caregivers with valuable tools and information in caring for a loved one with dementia. So today I'm going to share a little bit on the work that I've been involved in over the last 10 years and the role of research in supporting culturally safe Indigenous specific dementia care needs and resources. And I'll share some of the findings from our Indigenous dementia projects, as well as give examples from the Indigenous Cognition and Aging Awareness Research Exchange website, or we also call it the iCare website. And I'll share how these findings can lead to culturally safe resources, health promotion materials, and assessments. So I want to acknowledge the main people and communities and research partners, as well as the funders that contributed to the research and resources on the iCare site. And I want to give a special thank you to Dr. Kristen Jacklin and Wayne Worry for leading the foundational work on Indigenous dementia research. So in terms of an outline, I'll start with situating the research and looking at the rates of dementia in Indigenous populations. I'll then go through some of the key findings, looking at cultural understandings of dementia and perceptions of aging. And then finally, I'll give some of the examples of how we translate these findings into culturally safe tools and resources for communities and healthcare providers to use. So the next few slides, as I said, will give some information on what's going on in the literature regarding the rates of dementia. And I'll also go through how we came to do this work as well. So in terms of looking at the incidence and prevalence of dementia, so in our review of the literature, we found that there's limited data available to accurately represent the rates of dementia in Indigenous populations. So small studies that are available suggest that the rates of dementia in Indigenous populations around the world are higher than non-Indigenous peoples and continue to increase. So published systematic review studies suggest a high degree of variation in study designs and findings. And it's important to acknowledge that there are actually very limited data available in Canada or elsewhere that help us understand the prevalence of the illness. But when we put together what is known, we do see a pattern of higher rates of dementia in Indigenous populations. So in Canada, as I said, there's limited data that looks at the rates. And within the slide, we have data coming out of Alberta. And so Jacqueline, Walker, and Shawanda did find data from Alberta that looked at the linked data connecting the Indian registry to the health records. And they were able to establish that the rates were increasing, and they were increasing quite quickly. They also found that the age of onset was about 10 years younger, and more men were being diagnosed than women. And also that dementia was increasing at a faster rate in the First Nations populations. So in more recent studies, Jacqueline Walker looked at the projected dementia prevalence in First Nations populations in Canada and found that based on only age as a risk factor, the number of First Nations people over the age of 60 with dementia will increase fourfold by 2031 compared to 2.3-fold increase in non-First Nations populations. So we know the rates are going up. So in terms of looking at the work that we've done, so the Indigenous dementia research work that we've done in Ontario, the need for studies concerning Alzheimer's disease and related dementia was identified by communities back in 2007. And Manawzwin Health Services and Nojmoentag Health Center organized a roundtable forum on Alzheimer's disease and related dementias concerning Indigenous peoples. And participants at the roundtable identified the need for culturally appropriate screening tools and health promotion materials as well as for more Indigenous people to be trained to deliver services, and cultural competency training for healthcare workers. So Doctors Jacqueline and Worry applied for funding and were able to conduct foundational research looking at knowledge, attitudes, perceptions, and cultural values concerning dementia and aging in diverse Indigenous communities. So there's one study from 2009 to 2014, where they worked with 9 First Nations communities and 4 urban Indigenous organizations to produce 6 community reports looking at Indigenous people's understandings of Alzheimer's disease and related dementias. In 2014, they were able to obtain funding through the Canadian Consortium on Neurodegeneration in Aging, so CCNA Phase 1. And they're able to continue the research and build on and transition previous research findings into intervention-based research. So this research was done in partnership with the 7 First Nations on Manitoulin Island. And then with our more recent work, so this is the iCare project, so Indigenous Cultural Understandings of Alzheimer's Disease and Related Dementias, Research and Engagement. It expands upon the research to include more of a Great Lakes perspective. It includes partnerships with Red Lake and Grand Portage Nation in Minnesota, as well as the Oneida Nation in Wisconsin. So from here, I'm going to share a little bit how we do this work. So we use a community-based participatory research approach where we work in partnership with communities to carry out research that is important to those communities. So we maintain a commitment to equitable partnerships throughout the research process. And this includes adhering to the governance structures and protocols outlined by the community partner. So in our work with First Nations on Manitoulin Island, our research protocol goes through the Manitoulin Anishinaabe Research Review Committee for approval. And this is in addition to meeting with Chief and Council and getting band council resolutions and motions of support. We also work closely with local advisory groups, and that includes traditional knowledge carriers, language speakers, and caregivers. And the advisory group is an active partner throughout all stages of the research. We also engage in knowledge translation and exchange, which involves all partners in the research process and respects partners as reviewers, co-presenters, and co-authors in academic and community forums. And we also hire community-based researchers and maintain a commitment to capacity building and sustainable community-based research that develops and enhances local expertise, training, and education. So for our methods, we use a 2-eyed seeing approach in Indigenous research methods. So Mi'kmaq elder Albert Marshall explained that 2-eyed seeing was a gift where we learn to see from one eye with the strengths of Indigenous knowledge and ways of knowing, and from the other eye with the strengths of Western knowledge and ways of knowing. So an explicit 2-eyed seeing approach involves addressing the power imbalance between the 2 knowledge systems, placing Indigenous knowledge on equal ground with Western knowledge. So this includes incorporating Indigenous ways of knowing and privileging stories and storytelling as a culturally informed interpretation process, situating oneself in the research by taking the time to build relationships and following Indigenous protocols and being accountable to the communities that we work with by adhering to the 4 R's of research. So respect, relevance, reciprocity, and responsibility. So we also work from a framework of cultural safety. So cultural safety operates along a continuum, moving from cultural awareness to cultural safety, inclusive of cultural sensitivity and cultural competency. And although these terms may appear to be similar, they are distinct concepts involved in achieving culturally safe health outcomes. So cultural awareness concerns the healthcare provider's acknowledgement and respect of differences. Cultural sensitivity involves learning the history, customs, and practices of a particular patient group. And with cultural competence, a healthcare provider develops the skills, knowledge, and attitudes required to appropriately integrate a client's culture and values into a healthcare plan. And cultural safety involves the healthcare provider's understanding of their own cultural position as a result of historical and societal factors. So cultural safety is predicated on the assumption The healthcare provider's own culture impacts the manner in which the clinical encounter occurs, and there impacts the patient's care. So building trust with patients involves acknowledging the roles of socioeconomic conditions, history and politics in health, and communicating respect for the patient's beliefs and values, and ensuring the client is a partner in the decision-making process in the healthcare treatment plan. So this next slide here demonstrates how we bring everything back together and the different steps that are needed to turn research into dementia education resources. And so you'll see an article on the side there, and this article is by Charlene Webquemacod, Wayne Worry, myself, and Chris and Jacqueline, and we outlined how we developed and piloted the Indigenous dementia fact sheets. So in developing culturally safe Indigenous dementia education resources, we conducted a secondary analysis on the ethnographic data collected largely from 2009 through 2014. We also conducted a comprehensive review of the literature to understand other work that has been done in this area and see what other health resources are available. We consulted with local community advisory groups and elder advisors to ensure the health promotion materials were culturally safe and relevant. And then we piloted the tools and resources, as well as conducted ongoing reviews and held community and stakeholder consultations. So much like the NWAC toolkit in terms of going back through those sharing circles and getting people to share their experiences on the tools. So for this next section, I'm going to touch on some of our findings. And this is just a small snapshot of what we've found over the years. But I'm going to start with some of the foundational knowledge that was gathered to look at how diverse Indigenous communities experience dementia, and then move into some of our more recent findings. So with the foundational knowledge, we wanted to collect and analyze information concerning knowledge, attitudes, perceptions, and cultural values concerning dementia and aging in diverse Indigenous communities across Ontario. And this includes urban, rural, and remote First Nations and Métis populations. Our more recent studies focuses on First Nations on Manitoulin Island, as well as takes a Great Lakes approach by including Red Lake and Grand Portage tribal nations in Minnesota, as well as the Oneida Nation in Wisconsin. So throughout our research, both in Canada and the US, we found that dementia is often talked about and understood differently than the mainstream population. So cultural understandings of dementia that we heard were it's a part of aging, that going back to childhood is an accepted concept, and that visions, dreams, and visits from the ancestors are seen as natural and normal at this stage and not considered a hallucination. We also heard that it's part of the circle of life, and this goes back to the medicine wheel teachings. In our work, we found that there's no specific words for dementia in Indigenous languages in the communities included in the research. There are gentle or humorous descriptions of being confused, forgetful, or sometimes mixed up. So this next slide that I'm going to share is of Karen Pitawanakwit explaining how a person with dementia may be viewed. So Karen is an Anishinaabe from Wikwemikong Unciat territory, and she's a registered nurse with over 15 years experience as a community-based researcher. And I've had the honor of working with her since 2014. So I'll share this little clip.
And that we view dementia as the person still has the knowledge that they had before, but that it's just buried inside. We call it Ngushkawan, Wigakendom. So that's what that means, that it's just buried inside, that they're still who they were. And it's up to us to learn how to make their life a little better, a little happier, happiness, feelings of happiness and feelings of love and familiarity are really important. And that's how we view dementia. I think that's important for that to be understood.
So with this understanding that the person's still there, those memories are just covered, that's so important in providing care for the person, for healthcare providers to understand as well. So in terms of if the person is in long-term care, to have that understanding and to treat that person with kindness and respect and love. So also shared throughout the research was this concept of balance. And so it's important to share that most of the Indigenous people involved in our research acknowledge that in very recent history, dementia has become more frequent and is occurring at younger ages. So this worried older adults and healthcare providers. And we explored participant thoughts and explanations for these changes in dementia at both an individual and population level. In both cases, people's explanations came back to balance. So I'm going to read a quote that was shared by an older adult on Manitoulin Island. And they said, "This elder said to me, 'You're out of balance, you know?' When I first went to him for help, all he said was, 'You're out of balance.' So I think that Alzheimer's is being out of balance, for me anyway. So that's why I look at it not being able to function in a balanced way to your thoughts, your feelings, and your actions and acceptance. So the balance necessary for well-being is widely viewed as being related to colonialism and specifically to our participant group, to the changes in diet and lifestyle, disconnection from the land and culture, as well as trauma, intergenerational trauma, and unresolved grief. So in our more recent research, we also asked what helps people age well. And so many participants stated keep active, keeping busy, and keep on loving. So many participants felt that there's a strength in asking for help, having a connection to land and medicines, as well as being connected to youth, family, and community. They also talked about the importance of diet and food and healing from trauma. You know, having a positive outlook on life is also helpful for healthy aging. At the community level, looking at programs to support healthy aging. And then of course, they also mentioned visiting, dancing, laughter, fresh air, and sleep. And so I'll also share another quote by a traditional knowledge carrier from Wikwemikong. And they said, "You have to think of those body, mind, and spirit. And then if you think like your own self, you look at the 4 aspects. It's your physical self, your mental self, social, you know, how you interact with other people outside of you, you know, your family, your community, and then your spiritual. So, you know, it's all there." And this goes back to balance and maintaining those connections to family, community, and the creator. So as I said, that's just a small snapshot of some of our findings. There are a lot more on the website, and including reports that anyone could download for free. So next up, I'm going to turn to go through some of the turning research into resources. So look at some of the examples and how to transform the research findings into practical tools to support culturally safe care. So this is a screenshot of the iCare website, and you'll see there it's i-caare.ca. So over the past several years, we've been working on knowledge translation activities to try and move these research findings into practical tools for Indigenous people living with dementia, their families and communities, as well as healthcare providers and other researchers. To do this, we created the Indigenous Cognition and Aging Awareness Exchange website. And all the examples and tools I'll show within the next couple of slides are available on this website and free to download and use. So I'm going to start with the Indigenous Dementia Fact Sheets. So these were developed between 2014 and 2017. So these were developed with support from a contribution agreement with Health Canada and First Nations and Inuit Health Home and Community Care. So the development process included a literature review, an environmental scan of health promotion materials, the quality of findings from our earlier research, the Perceptions Project, as well as ongoing meetings and review process with community and stakeholder consultations. So we started with 4 fact sheets, and this included what is dementia? So Indigenous perceptions and cultural understandings of dementia. We also looked at signs and symptoms of dementia, really drawing from our research. So looking at an Indigenous guide to signs and symptoms. And then what to expect after a diagnosis and preventing dementia as well. So the path of dementia goes through the trajectory of the disease and the possible care needs that people may have at each stage. The medicine wheel on the far side of the screen, that one was developed with the Community Advisory Council on Manitoulin Island. So they asked our team to put the information shared in the prevention fact sheet into a medicine wheel. And this would give clear examples of activities that can be used to support one's physical, emotional, mental, and spiritual health. So I believe Laura reached out a couple months ago asking to see if NWAC could include this medicine wheel in their toolkit. And the Manitoulin Advisory Council were really excited about this because they kept thinking, you know, as long as it could help people, it should be widely shared all throughout. So they're excited to be a part of this process. So also this next one is Pieces of My Relationship. So this example is a partnership between the Northeast Behavioral Supports Ontario, our research team and community partners, as well as Mamazing North Shore Community Health Services. So Behavioral Supports Ontario offers psychogeriatric consulting services to older adults exhibiting responsive behaviors as a result of cognitive impairment, mental illness, or substance use. So the Northeast BSO team developed a tool called Pieces of My Personhood for BSO staff members to use with clients to identify aspects of their personhood that will enable staff to offer more personalized services. So this type of tool may be used in a long-term care facility or with home care services. And the categories within the original Pieces of My Personhood tool tend to focus on the individual and may be seen as egocentric and in conflict with Indigenous cultural values and teachings of interrelatedness and humility. So the Northeast BSO understood that the Pieces of My Personhood tool may not be appropriate to use with Indigenous older adults and asked our team to help with the adaptation process. So for this, we started the project by working with an Anishinaabe expert language group on Manitoulin Island to translate the concepts into Anishinaabe-Mowin. And then we conducted focus groups with 3 distinct communities, and we were able to prioritize Indigenous knowledge and voices throughout. We also used Indigenous protocols in each of the areas, and we created a safe environment to share those experiences. So while personhood focuses on the individual and their own lived experience, the term relationships reminds us to focus on the person and how they view themselves in the context of their relationships to the people around them, to the land, and to their story. So this partnership resulted in the creation of 4 different documents. So we have the Pieces of My Relationships tool. We also created a family supplemental tool, just in case the person being interviewed on the tool wasn't comfortable sharing certain aspects of their life. The family could help fill that in. We also have the quick guide to approach, and then a guidebook on the adaptation process and how to use the tool. So again, all that's available on the website and able to download and use. And then for this one, this is the Canadian Indigenous Cognitive Assessment. So it was conducted in partnership with each of the First Nations health authorities on Manitoulin Island, along with Nojmo-Teg Health Center as well. And we worked with researchers from Australia who worked with Indigenous people from the Kimberley region in Australia to develop the Kimberley Indigenous Cognitive Assessment. And, after meeting with our advisory group and reviewing the KICA with a K, the Community Advisory Council in Manitoulin expressed that this would be a really good tool to adapt for use with Indigenous people in Canada. So we adapted the cognitive screening tool, which is one of 4 tools in the assessment toolkit. And the adaptation involved an iterative process where an advisory group, an expert Anishinaabe language speakers, team members, and a key expert panel of healthcare providers analyzed each assessment domain and adjusted the questions to reflect the local cultural understandings and nuances within the Anishinaabe language. So after the adaptation, we did a pilot, reliability testing and validation of the KICA. So the reliability and validation of the tool was led by Dr. Jennifer Walker, and the KICA was found to be a valid and reliable test for cognitive screening. So this just, again, shows you where the tools are available. So the KICA can be used by formal and informal caregivers, healthcare providers, and allied health staff in the loved one's home, their community, or in a healthcare setting. So it can be used wherever there is a change in cognitive function or health status, or where cognitive impairment is suspected. So the KICA is ideal for Indigenous older adults, and it's gentle and culturally safe test that might help mitigate any anxiety along cognitive testing. So on our website, we do have the KICA assessment along with training videos available. Again, all these are free to download and use. And with the training videos, so we actually had the Anishinaabe expert language members. They're really excited about being able to put together a training video. And so they asked if they could be the main actors within the video. So we have 4 different videos, an English version, an Anishinaabe version, translation with Anishinaabe to English, and then with sign language as well. So just in terms of a recap, so with this, a lot more research is needed on the rates of dementia and how best to prevent, treat, and care for people living with dementia in diverse Indigenous populations. Also, there's a need to work with communities and respect the cultural understandings and knowledge of dementia. So working with communities utilizing a culturally safe 2-eyed seeing approach can lead to improved supports, services, and programming. And finally, more culturally safe resources and tools are needed to increase awareness and promote access to care. Just want to say miigwech, and if you have any questions or comments, please feel free to ask me, or I'll also put up my contact information as well, so you're free to email me at any point in time. I also have here website, as well as you can follow us on Twitter. Thank you.
Thank you, Melissa. That was amazing. That was so much information, and I feel like I could listen to you talk about this all day. So thank you for sharing that. We have a couple of questions that I can share. So one is Debbie asked, sharing circles sound amazing. And I think this is a question for Laura. Are there sharing circles available for those living with brain changes or dementia?
Currently, no. So this project, Circle of Care, focused specifically on the caregiver. And for a number of reasons. So previous to this project, we had a different dementia project that focused on stigma and getting people to seek support to learn more about dementia. And one of the findings that that came from that project was that there was lacking support for caregivers specifically. So there are a number of programs for adults with memory loss or dementia through other organizations, but there definitely was a gap as far as programs available for caregivers. And given that so many Indigenous people with dementia or memory loss stay home or are cared for at home, it was definitely something that needed to be addressed. Something that again we heard across the board, that more programs for caregivers, more support for caregivers specifically were needed. So this project specifically is for caregivers.
Sounds like a great future project, perhaps. That's great. Okay, another question was about, and I'm not sure if this is specific to Melissa or Laura, but someone asked if they could provide some examples about the types of Indigenous protocols that were undertaken by the project team.
Yeah, so I could talk a little bit more about the pieces of my relationship tool. So for each site, so we work closely with our advisory group on Manitoulin Island. Also, we worked with Anishinaabe Expert Language Group when we conducted the focus groups in different areas. So we reached out to local communities. We held a focus group on the North Shore, so working with elders from that area, offering tobacco, asking them to help with the focus group and make sure that participants, so opening up the focus group in a good way, offering a prayer and being there for participants just in case they needed any additional support. And then after the research, having that contact person in place, we're able to share all the information back and be able to take the information back to those communities as well. So I hope that's helpful.
Yeah, and if I can just speak to some of the protocols that were used for our sharing circles, are very similar to what you mentioned, Melissa. So having the knowledge keeper there to open and close the circle in a good way. What I forgot to mention during my talk was that the knowledge keeper is there also burning medicine. So she'll be burning cedar and tobacco, and that's ongoing like throughout the circle. And it's something that's done in person, but also virtually. It's also done. So that was one of the things that one of the main ways that we incorporated sort of Indigenous protocols. And I also wanted to mention, we also have to compensate the knowledge keeper. So that's, we, in recognition of her expertise, of her time, of the fact that she's, really creating this very comfortable and safe space for participants. So that is, I think, a part of it that is important to recognize as well.
That's great. Thank you for touching on that, Laura. That's important. And Melissa. Okay, there's lots of great questions now. Laura was one asking, she said, acknowledging the relations and not just the individuals seems so important for others as well as Indigenous peoples. Can you talk about the changes that were made in adapting pieces of my relations?
Yes, so when we started going through the tool, there's a list of about, I think there's 23 different questions, and the assessor would sit down with the person and go through it and not be a formal interview of asking question after question, but trying to create more of a space where they could share information. What we did is further expand upon that in terms of looking at different key areas. So I think we had 5 different key areas where we could get people to talk about, a little bit about themselves and their families. And so, one of the questions also involved asking if they had any pets or anything like that. So something that might bring a lot of joy. We also asked what helped keep them safe. So what helped keep them safe? When we got through some of the questions that might elicit more emotion, we had also asked in terms of, what do they do to when they're grateful. So what do they practice when they feel grateful? Is there certain ceremonies or prayers or anything like that that they do as well? So, and then asking people, you know, how can they be, you know, if they need to pray, especially in some of those long-term care facilities, if a person was used to smudging every morning and then they're in a facility where they're not able to do that, you know, what would help them? And so that kind of goes a little bit further along, making changes at the institutional level as well. So.
Thanks, Melissa. That's great. Okay, there's lots of questions to choose from. Actually, I'll read Myrna. Myrna Norman is one of our community advisory committee members that is known to many people. She's a fabulous person living with dementia. So Myrna said, "Bravo, amazing work. I believe these tools will help to provide great tools, particularly the perception of people living with dementia." So this is great. And okay, there's a question about evaluation. So do you have any comments to make about evaluating these types of initiatives, i.e. getting the perspectives of Indigenous communities on new tools and services in a culturally sensitive way?
So maybe I'll speak a little bit about the evaluation tools for for Circle of Care. So our from the beginning, it's been ongoing consultation with people in different communities. The project was designed to have, you know, a lot of back and forth between the project design, the resources, and the community members who would potentially be using the resources. So again, it's been a constant dialogue between the research team and participants. For a more formal evaluation, and you know, a lot of this was for reporting purposes for the funder. They're looking for specific information. So for that part of it, we found the best way to do that was just a short survey, keeping it as simple as possible. Sometimes it can be difficult to have people provide feedback to the survey. You know, once a circle is done, it's done, and then it's sometimes a challenge to complete even a short survey. So one of the strategies that we employed was to sort of integrate some of the evaluation markers that we were looking for into the sharing circles themselves. So we would be receiving feedback in real time. Again, people are always encouraged and welcome to share any feedback that they might have, any information that they wish that they had had when they began their caregiving journey. And people have been participants have been very, very generous sharing the things that you know, they know now or wish they had known then, things that they feel are missing, not just from our toolkit, but in general, right? Resources that could be useful for them. So these are things that are encouraged during the sharing circle. And yeah, a survey, but honestly, the best feedback I feel is the direct feedback that we receive during the sharing circles.
Great. Melissa, anything to add to that one?
Just, yeah, that ongoing feedback is so important. So, you know, reaching out to the community partners, stakeholders, and just, I know with the pieces of my relationship tool, we do have a survey on our website for people who have used it and just asking, you know, what did they like about it? What would, have they used it? What would they change? And unfortunately, we haven't had a lot of feedback there, but for people who have used it, they've really enjoyed it. And same with the fact sheets as well. So with the fact sheets, we've shared those quite broadly. And so we always are asking people, you know, like, is this relevant to where you live, especially with bringing the fact sheets down to the US as well. So try and find ways always to improve upon the resources and make sure that people are getting the supports that they need.
And if I could just add, because you were just talking now, Melissa, the wheel. So that was not something that we were going to include initially in the toolkit, but we had such great feedback from caregivers that, you know, that was something that they really enjoyed and a really great tool to have. So, you know, that kind of ongoing feedback is pretty central to the resources that have been created through the project.
Thank you.
So it sounds like the flexibility is also really essential, like being able to be flexible and kind of pivot and add things as needed. Okay, there's another question. This one is for Melissa. So this person said, I was wondering if you have been keeping track of how the tools have been adopted in long-term care homes or home care, and whether you have any tips for implementation and dissemination.
So I know with our research partners through the Northeast Behavioral Supports Ontario, they would be really interested in doing a pilot study. So reach out to me and I could put you in touch with them. Unfortunately, there wasn't additional funding to be able to continue that work. So with the adaptation that kind of took part on, I guess, the side of our desk where, you know, we had partners who said, this is really important. We really want you to do this, but it was all internal funding to make this happen on both our parts. And so for that next phase, being able to have partners who would want to implement this and go forward from there. So, yeah.
I know who asked that question, so I've started an email. I'll connect the two of you.
Perfect.
That's great. And there's a really great comment in the chat that I just wanted to translate from Emily. So Emily said, thank you especially for the the iCare tools, and that they're going to share those with their partners on the Huron-Wendat Nation, their council there, who have opened a new and unique long-term care center there in the community. So that's great. Thanks. That's one of the DCI projects. Amazing. Okay, so we've got about 2 minutes left. What I will do is we have an evaluation. We'd love to hear what you thought of today's webinar and just your suggestions for future topics. So I'm going to put the link to the evaluation in the chat. And of course, I will say a huge thank you to Melissa and to Laura for sharing so generously with us. This was an incredible amount of knowledge and learning to pack into just under an hour. So it's truly impressive. And we're so grateful that you were able to join us today.